What about odinophagia? Painful. Excellent. So there are a few terms you should know about them, and you ask the patient, clarify from the patient, what does he exactly complain? What's exactly complain? Is it like difficulty of swallowing or painful swallowing? Because it's commonly confused, these two symptoms. Another symptom is something called global sensation, which is the sensation of lump in the throat. How we can differentiate between dysphagia and global sensation? How we can oh, excellent, excellent. So global sensation is feeling of foreign body or abnormal sensation in the throat all the time, even between the meals. Global sensation can be caused by many different etiology, from reflux disease to uh, malignancy, could be due to psychological even. So it's wide differential for global sensation. So we will concern about odinophagia and dysphagia. But always you have to clarify what does it mean dysphagia. So how many types do we have for dysphagia? How many types dysphagia do we have?
Two types, oropharyngeal and esophageal.
Excellent. So we have two types of dysphagia, can be oropharyngeal, can be esophageal. If you go back to the mechanism, pathophysiology of swallowing, you will see there is two phases or three phases. First, we have oral phase of swallowing, which mainly for formation of food bolus after mastication. And then it will be followed by oropharyngeal phase, which will ensure and ensure propagating the food bolus into the esophagus. Different mechanism will happen to ensure transition of the bolus from the mouth to the esophagus without aspiration. And then esophageal phase, at this phase, upper esophageal sphincter will relax, then the bolus will go to the esophagus and it will pass the food bolus into the stomach. This phase is involuntary. This phase mainly involuntary. This phase is voluntary. So if the patient have difficulty or a problem or any pathology in this phase, we call it oropharyngeal dysphagia. If the food bolus passed the esophagus or upper sphincter and left the oropharyngeal area, then the patient developed symptoms, we call it esophageal dysphagia. So how we can differentiate from the based on symptoms. So the first thing we'll do with the patient whenever we interview them, we'll take history. So from history, how we can differentiate between oropharyngeal and esophageal dysphagia. And it's very important to differentiate based on history.
Can they swallow by themselves? Do they feel the difficulty when they actively swallow or after they swallow?
Excellent. So difficulty during active swallowing. What else?
Any associations with dysphagia, like regurgitation?
Like what?
Regurgitation.
Excellent. Regurgitation. So it's very important to differentiate between the two based on history. And it can be almost 80% you will diagnose the type of dysphagia based on history alone. In oropharyngeal dysphagia, the patient have difficulty of initiation swallowing. Initiation swallowing. On the other hand, if you compare it with esophageal dysphagia, the patient can swallow, but few seconds later he will feel the food bolus stuck either in the chest or the upper abdomen. So then the patient will feel sensation food getting stuck in the esophagus. So he started the swallowing and then he felt the food stopped in the chest. In oropharyngeal dysphagia, he has difficulty of initiation. You remember the pathophysiology when we go, this process impaired. The process of transition of the food bolus from the oral cavity through the pharynx to the esophagus is impaired because these muscles will coordinate the movement of the bolus. If there is something occur in this area, will cause oropharyngeal dysphagia. So it can be associated with coughing. This is a clue that could be due to esophageal oropharyngeal dysphagia or choking. Once he tries to swallow, the food will go to different tract, will go to the nasopharynx, nasopharyngeal regurgitation. Because this simultaneous contraction of the pharyngeal muscle is not coordinated in the right way. Aspiration, sensation of residual food remaining in the pharynx, or the patient have drooling. Is it clear? Was the scenario ايوه
يعني
تعني انه شو اقول لك يسعبل واضحه
اوكي واضح.
يصير اللعاب يعني يصير especially if the patient have stroke for example and there is mouth deviation and with facial palsy he cannot close his mouth so the saliva will start to drool right um, this indicate could be neurological problem واضحة الآن طيب other thing you have to know you have to know the age of the patient. There is certain diagnoses occur in elderly and other diagnoses can happen in younger patient. And as we mentioned, is it initiation or feeling food stuck in the chest? Is there other associated symptoms? What type of food? Is it like solid or liquid or both? Or started with solid and then solid and liquid? So what's the course of dysphagia? Was it sudden or he had it chronically for a long time and comes and goes? Is it progressive, intermittent? What is the site? So all these description, all these feature can give you clue about the likelihood, what type of disease he's having. Other associated symptoms you have to ask: loss of appetite, weight loss, nausea, vomiting, regurgitation, food particles, and so on. If there is history of chest pain, anemia, aspiration, and also you have to know about the risk factor from past medical history, diabetes mellitus, scleroderma. So scleroderma, what do you think type of dysphagia the patient will have in scleroderma? What's scleroderma?
Mixture of collagen in different areas inappropriately.
Excellent. So it's part of connective tissue disease. There will be thickening in the could be skin or the mucous membrane and can affect GI system. So what type of dysphagia do you think the patient might have? Is it oropharyngeal or esophageal? So scleroderma can usually cause affect the motility of the esophagus. So I'm expecting esophageal dysphagia. What about AIDS and cancer? Could be due to yeah, could be due to infection. This can be esophageal, can be oropharyngeal, both. Neuromuscular disorder like stroke. What do you expect from stroke and Parkinson?
Both. We expect both.
Esophageal and oropharyngeal.
But mostly oropharyngeal because it's
Dysphagia.
Yeah, excellent. Yeah, this is common actually with stroke patient. They will have dysphagia. It's very common. So, what type of dysphagia? Usually, they have oropharyngeal dysphagia. So, medication, how it can cause dysphagia?
Affect the motility.
Usually, with direct injury to the esophagus, it can affect even the oral mucosa. A patient with previous history of surgery and radiation. So, next slide. In terms of esophageal dysphagia, it can be due to mechanical problem or motility. Mechanical, that means something obstructing the lumen, something obstructing the porous from going through, or can be due to motility. The esophagus is not contracting the right way. Mechanical cause, mechanical lesion, can be due to something within, inside the lumen, or something compressing from outside. So the disease that can cause intrinsic lesion could be due to esophagitis, stricture, or acoustic injury from alkaline or acidic material, can be due to malignancy, peptic stricture, disease like eosinophilic esophagitis, infectious causes like infectious esophagitis, bill esophagitis or bill-induced esophagitis, post-surgical. If the patient had radiation due to any malignancy, they might have radiation esophagitis, rings and webs, or lymphocytic esophagitis. So these can cause, and the list is actually more than this, but this disease can cause some abnormal swallowing due to lesion inside the esophagus. Something could be something compressing from outside the esophagus, like aberrant subclavian artery, a cervical osteophyte, a large aorta, a large left atrium, mediastinal mass, or maybe there is no mass or lesion that obstructing the lumen, just the esophagus is not contracting the right way. There are two different categories. Motility disorder can be primary, like achalasia, diffuse phageal spasm, knitted crackers, or secondary motility disorder, like scleroderma, that affect the motility. Diabetes can affect the motility. So, if you want to investigate these types, so all of them, they will present with oropharyngeal esophageal dysphagia. So, if you want to choose test, look for something intrinsic. What's the best test you will do?
Endoscopy.
Excellent. Endoscopy. If you thought about something inside the lumen, then endoscopy. If you are suspecting something pushing from outside, what you will do?
CT.
CT or barium study. If you want to look for something affecting the motility,
Manometry.
Manometry.
then manometry. Then manometry. Excellent. So is it clear? So far clear, right? Again, dysphagia can be oropharyngeal or esophageal. Oropharyngeal can be due to structural disease or due to propulsive or motility. Structural disease that can cause oropharyngeal dysphagia could be Zinker diverticulum, neoplasia, cervical web, osteophyte, congenital abnormality, radiation infection, and so on. Motility disorder that can affect oropharyngeal dysphagia can be either due to neurological disease or myopathy, like neurological CVA, like stroke, Parkinson disease, ALS, brain tumor, Guillain-Barré disease, and so on, multiple sclerosis. All these diseases can cause oropharyngeal dysphagia. Can be due to problem within the muscle itself, like myasthenia gravis, polymyositis, connective tissue disease, paraneoplastic, and so on. If the patient's symptoms goes with esophageal dysphagia, then we have to know, Is it like due to motility or structural pathology? If it's motility or propulsive, what's the clue? The patient will tell you, or you will find it in the exam. The patient have solid and liquid dysphagia because the esophagus is not contracting well. So the either solid or liquid, both of them will be there. So the patient have solid and liquid dysphagia. That means it's a propulsive problem or motility problem. Examples: the patient might have GERD with weak peristalsis, might have achalasia, diffuse pharyngeal spasm, secondary motility disorder like sclerodermy. If you hear solid and liquid, think of motility. Or could be structural disease. Again, depending on the description of the patient. Is it like intermittent, comes and goes? Then think something causing narrowing of the lumen, like Chatsky ring, esophageal web. Is it something progressing? Like started a few years ago, not few, let's say 1 year ago, and getting worse every time. It's not comes and go. It's steady worsening. Think of malignancy in the right scenario. It's variable, sometimes come and goes, sometimes progressive. There's no clear cut course for the lesion or the symptoms. Then other differential diagnosis could be peptic ulcer disease or peptic stricture, eosinophilic esophagitis, hiatus hernia, extrinsic compression, and so on. If the patient complains from pain during swallowing or odinophagia, then think pill esophagitis, infectious esophagitis, chemotherapy, mucositis, especially in patient with chemotherapy or bone marrow transplant, or Crohn's disease, Paget syndrome, and so on. Is it clear? So far clear?
ايش؟ كلير بس كثار قوة دكتور، يعني هل مطلوب احفظهن؟
لا لا تحفظ لا تحفظهن، بس لكن اعرف وش الديزيز اللي انا يعني I don't memorize all this list, but I know this disease usually come with these symptoms. طيب you don't need to memorize it, you need to understand it more than memorization. For example, if patient come with sudden onset with picture of any difficulty of initiation swallowing with nasal regurgitation, and his age around 60, hypertensive with or risk factor, what do you expect? With facial palsy, what do you expect? What's with let's say hemiplegia, then I will think he might have stroke. So the scenario, it will give you the clue, right? So how to investigate these pathologies? Can be with barium. We have two different types of barium. Barium swallow, it will look for the esophagus, and we have modified barium swallow. Barium swallow will use like X-ray or fluoroscopy and ask the patient to drink contrast, and it will take picture of the contrast whilst passing the upper esophageal sphincter until the stomach. Modified barium swallow is different type of fluoroscopy. The patient will give different thickness of solution, and he will drink it slowly, and the picture or the fluoroscopy will be focused on the oropharyngeal area. So it will take video of the swallowing process. So if we are concerned with oropharyngeal dysphagia, then modified barium swallow. Esophageal barium swallow. If we are looking for the lumen within the lumen, then EGD, upper endoscopy. Nasopharyngeal laryngoscope if we are concerning with oropharyngeal cause, and then for motility, esophageal manometry. Other type of investigation to exclude certain diagnoses, like plain X-ray for foreign body, cervical osteophyte, MRI if you are suspecting, or CT for stroke, CT chest if you are suspecting mass, mediastinal mass, and BH study if you are suspecting reflux disease. You can see this is called modified barium swallow, and this one barium swallow. You can see the modified barium, it will be focused on this area mainly. It's video, right? Type, which one you will choose? Is it for esophageal dysphagia? Is it barium esophagus or endoscopy? Usually depend on the scenario. If I'm suspecting upper esophageal lesion or narrowing, or patient he had history of, for example, cancer, then I would do barium first to see the anatomy before inserting the scope, because in the proximal part of esophagus, usually blind procedure, we cannot see much. If there is a lesion in this area, we might not see it. So if there is history of proximal lesion, surgery, zinker, cancer, and whatever, then think of barium first and then endoscopy. Esophageal manometry, upper endoscopy, if upper endoscopy normal and suspecting esophageal disorder, motility disorder. What's the manometry?
The device that calculates or register the peristaltic movement of the esophagus.
Excellent. So it's a tube. We're using tube, right? Insert from the nose till the stomach. It has hundreds of sensors. This sensor will measure the pressure in upper esophageal area and lower esophageal area and ask the patient to drink water. During the swallowing process, it will measure the pressure in each segment of the esophagus until the bolus or the water will pass to stomach. So it will represent it in this picture, relaxation of upper esophageal, so the fluid or the bolus went inside, and then you can see propagation of the contraction through the esophagus until reach the lower esophageal sphincter, which was good relaxation. If there is any abnormality in this pressure with different measurement, and then we can say what type of disease he's having, if it is motility. Right. If a patient with esophageal dysphagia and you're suspecting upper esophageal lesion, then barium study or endoscopy. If you do endoscopy, you might find the lesion which intrinsic within the lumen, could be ring, could be stricture, diverticulum, and so on. If it's normal and your patient have dysphagia for solid only, solid, so I'm not thinking motility. ECG of the esophagus, صحيح. So if the patient have only solid dysphagia, I'm not thinking it's motility, so it's not solid and liquid. Then I will do barium if EGD normal and if barium was not done. If barium is negative, EGD is negative, then I might do manometry. Manometry can give you answer about is it like primary esophageal motility disorder or secondary or what type of disease. Now we'll review some cases. If the patient present with painful swallowing or painful swallowing or dysphagia, and he's having high risk, and during examination it showed this picture, cheesy black on the mouth, then this is likely, or what we call candidiasis, esophageal candidiasis. The patient presents with odynophagia or dysphagia for liquid and solid and maybe asymptomatic, usually immunocompromised, or he had history of steroid, antibiotic, or inhaler for bronchial asthma, for example. Endoscopy reveals white mucosal plaque and esophagitis. So what's the treatment? Antifungal, right? But usually if you see the patient with oral fungus like this, you can see the candida, then you don't need to do endoscopy. Just start empirical treatment. If not respond, then perform endoscopy. So always for candidiasis, start empirical in the right patient if he is immunocompromised. Let's take questions now. So we have 50 years old lady was taking multiple medications. She was presented with dysphagia and underwent gastroscopy, which reveals proximal esophagus ulceration. While reviewing her medication, you suspect medication-induced esophagitis or pill-induced esophagitis. You can see here ulceration in the upper esophagus. So which of the following likely the culprit? Think about the answer. C, D. So which one? Is it multivitamin can cause this picture? Or Dysphagia, metronidazole, doxycycline, metoprolol? Let's see the answer. Oh, يبدو لي سكرته. اعتذر. مرة ثانية سريع. Choose the answer. So the majority of you choose D, doxycycline, and like 7 choose metronidazole, and only 1 multivitamin. So the right answer is doxycycline. So how it will cause injury? How it will cause Dysphagia or esophagitis? Uh, some certain of medication that can cause esophagitis or gastritis. Example, common antibiotic like doxycycline and clindamycin could be due to aspirin, bisphosphonate, potassium chloride, quinidine, and iron. So if the patient drank or took the pill and did not drink enough water, they might the capsule itself it can stay in the esophagus and can cause mucosal injury. That's why always whenever patient taking medication that's known to cause gastritis or esophagitis, to advise them to take the pill while they are standing, especially bisphosphonate. Especially bisphosphonate. Ask the patient to take it while they are up, sitting, not lying down, and even after 30 minutes after swallowing, and drink plenty of water because these can cause esophagitis. So you need to know what type of medication that can cause esophagitis. That's why drug history is important during dysphagia. So second case. So we have 70-year-old male patient with long-standing history of dysphagia for solid food associated with frequent episodes of coughing and choking during sleep. His wife noticed that he has foul-smelling breath. What's the best diagnostic modality for this patient? Is it like CT head, gastroscopy, barium, or esophageal manometry? So what do you think? واضح عندكم الخيارات؟ خلينا نشوف ابديت. لا طيب
ما يمدي أنا.
ممتاز ممتاز. Remember his age? Let's see the answer. 10 they did not answer. 26 choose barium, 7 choose CT head and gastroscopy. So why CT brain? Why do you think he need CT brain?
He's old and feeling a mass, so we
Excellent.
think about cancer, maybe, or a mass.
Excellent. Right. This is one differential. What about gastroscopy? Why gastroscopy؟ أحد يغير بالإجابة، خلاص اخترت الإجابة أنت الموضوع، أحد يغير إجاباتها. طيب why gastroscopy؟
Because I thought about fungal يعني ممكن fungal فبشوف من داخل لأنه foul smelling.
Excellent. Right. What about barium?
It appears to
Why
be
barium?
oropharyngeal, and there is cough and choking and foul smelling. I want to see the anatomy. It's only to solid food, so there is no functional problem.
Excellent. Well, what about manometry? The one who chose manometry. فيها. So the right answer is barium's study. But why is that? If you look at his age, 70 years old, with long-standing history. Long-standing history. So will you think of malignancy if patient had long-standing history of any disease? It will be unlikely. Usually malignancy will be progressive over like a few months. He might have non-specific symptoms, but it will not be steady for a long time. Dysphagia for solid associated with frequent episode of coughing, choking during sleep. So if you hear coughing and choking, is it oropharyngeal or esophageal?
Oropharyngeal.
So oropharyngeal. But here in the scenario they gave you a clue. So it is oropharyngeal, but occur during sleep. Why during sleep? Not during eating. 1 second. Why during sleep? Why not during eating?
GERD increase at
Okay,
sleep.
could be GERD. GERD can cause coughing while you're lying flat. Could be. But GERD will not cause dysphagia. Not this type of dysphagia. Change in position. Okay, it has something to do with change in position because relaxation of the muscle. Okay. طيب. What about foul smelling breath? Pouch, excellent. Pouches. طيب. So whenever you hear elderly with oropharyngeal dysphagia and they give you clue in the scenario, for example, he's coughing while in sleep or choking while asleep, or he had change of voice, or he had like mass feeling of mass compressing his neck, or he's regurgitating undigested food, then think about diverticulum or pouch. So what's zinc diverticulum? Because oropharyngeal dysphagias are likely to be helpful for me at this point. So as initial test, I will not choose manometry. So Zinker is simply herniation of mucosa and submucosa of the hypopharynx through a weak area of the posterior hypopharyngeal wall. So this is the upper esophageal sphincter. Just proximal to upper esophageal sphincter, there will be weakness and herniation of mucosa and submucosa. We call it Zinker diverticulum, right? So if the patient ate, the food will accumulate in this area. And then when he lie down flat, it will go up and he will start to have choking, or the food will go to the trachea. So then he will cough. So usually located proximal to upper esophageal sphincter, increase with age, more frequent in women. Symptoms of oropharyngeal dysphagia to solid and liquid, coughing, choking, and throat pain, and with swallowing. Associated with regurgitation, undigested food, halitosis, which is bad foul smelling, excessive salivation. The problem with zinker, because I told once we enter with scope, usually this area it's not clearly visualized by endoscopy, so we pass this area quickly and we might not see the diverticulum. So the actual examination with endoscopy usually from this area and down. So that's why sometimes it can be missed during endoscopy. Best diagnostic test to do barium swallow. Barium swallow. Treatment can be surgical and cricopharyngeal myotomy, or endoscopic sphincterotomy can be done for it. Clear? Okay, another question. 65-year-old male, known case of GERD, BBI. He presented with progressive dysphagia the last 3 months. Started with solid food, progressed to have difficulty with food solid, with both solid and liquid. He lost around 10 kg for the last month. What's the likely cause for his presentation? تشوفون الخيارات ولا تشوفونها؟
الا دكتور بس البول عندنا مو
لا تختارون. طيب خلاص اوكي. Go ahead. شوف الأنسر. Majority choose GL cancer, 8 choose achalasia, and 3 choose peptic ulcer disease. Why achalasia? What's in the scenario? Give us a clue about the achalasia. So he's 65-year-old male patient, okay, and he's known to have GERD, present with progressive dysphagia, 3 months. Started with solid food and then progressed to have difficulty of both solid and liquid, and lost 10 kg. So what's the scenario goes with achalasia? راح يجاوب ولا؟ طيب to save time.
ممكن لأنه عنده ديسفيجيا يعني، إنه لأنه سوليد ليكويد.
excellent. طيب اوكي but طيب خلينا بس نختصر الوقت. The right answer is esophageal cancer. But why is that? One, elderly. He's having long-standing of reflux disease, which is risk factor. Present with progressive. This is the key. Dysphagia for short time, 3 months. So it's not progressive for 2 years, 3 years. No, it's within short time he start to have his dysphagia getting worse. Initially started with solid and then continued to be solid and liquid and lost 10 kg. The way to think of it, like there was narrowing, structural narrowing that can pass liquid but not large solid food. Then the narrowing start to get worse until it's completely blocking the esophagus. Then no more solid, no more liquid. Make sense? So the progressing
واضح دكتور
worsening of
بس
dysphagia or the lesion, which can give you. Okay, go ahead. تفضل.
متى
بس
قلنا
إيش؟
long standing؟
إذا شك مريض زي المريض الأول for كم سنة long standing. If it's more than a year dysphagia, I don't think it give you a clue about malignancy. Still, now we are thinking out loud what there could be differential diagnosis based on the history alone. Achalasia, is it possible achalasia? We mentioned this age, it's unlikely, usually in younger age. Eosinophilic esophagitis, usually intermittent. Peptic stricture, it could be, yes. But I will not put it the first one, peptic stricture. By the way, peptic stricture can cause similar presentation, but not quickly as like within 3 months he start to have worsening. Usually it will take longer time. So typically present with rapid progressing solid food dysphagia. 75 report weight loss. The main culprit could be adeno or squamous cell carcinoma. Most frequently occur in distal esophagus. Risk factor Barrett's. That's why long-standing reflux disease is a risk factor. Barrett esophagus, smoking, obesity. AGD with biopsy usually diagnostic. It can be metastasized to other organ. This is the esophagus. Looking at gastroesophageal junction, you can see there is frail bleeding mass. Inside the stomach, doing retroflexion, looking at the cardia from inside. This is the scope. Looking at itself, this is the mass. This is lower esophageal mass. So if there is severe narrowing of the lumen, then it will not pass any liquid or solid, but usually start with small, intermittent this solid food dysphagia, then it would think continue till the patient have continuous dysphagia. واضحة عليها سؤال هذه ولا شيء؟ طيب خيارات مرة ثانية نرجعها.
دكتور سؤال
عامر.
ما يعمل لك. بالنسبه للويت لاس دكتور، بسبب انوركسيا يعني الكانسر ولا الفود انتيك يصير يقل بسبب السوليد فود؟
Could be both. Malnutrition, decreased appetite, effective malignancy. Can be both. I will come another case. We'll see. يعني, there is other case can cause also weight loss. Right. 18-year-old male patient presented with bronchial asthma, presented to the emergency department with difficulty for swallowing after eating steak. He has history of recurrent episodes of solid food dysphagia for the last 6 months that resolved with drinking sips of water. No weight loss. What's the likely cause for his symptoms? Eosinophilic esophagitis, achalasia, esophageal rings, and or acute esophageal spasm.
معلش دكتور, known case of what?
Bronchial asthma, BA, bronchial asthma. ER معناها emergency department. في بعض المصطلحات لازم تعرفونها زي مثلا BA bronchial asthma, HTN hypertension, CAB community acquired pneumonia, IHD ischemic heart disease, CVA stroke. هذه ما هو يعني مصطلحات وين ما تروحون بأي مكان في العالم راح تكون موجودة يعني. We recognize. فلازم تعرفون تتعودون عليها. غالبا في المستشفيات تكتبوا اختصارات لأنها معروفة وأسرع. يا صحيح، المفترض أن ما يكتب، ما يكثر من اختصارات، لكن عشان ما تتفاجئون إذا طلعتوا المستشفيات تشوفون اختصارات ما عمركم شفتوها، لا، اعرفوها من الآن. طيب. So let's show the answer. Majority of you choose A, eosinophilic esophagitis, achalasia to esophageal ring stiffen and esophageal spasm. So why eosinophilic esophagitis? What's in the history give you a clue about eosinophilic esophagitis? Okay, bronchial asthma. Okay, what else? Bronchial asthma. Bronchial asthma can cause other disease also. Young, okay. What else? First, is it oropharyngeal or esophageal? Let's start from here. Oropharyngeal or esophageal? What type of dysphagia do we have? Esophageal. Okay, why? Because he's having difficulty swallowing after eating steak. So it's not initiation. Then, what's the description of the dysphagia? Is it like solid or liquid? What type of food? Solid. So is it motility? Unlikely. I don't think it's motility, right? Why? Because it's solid food, not solid and liquid. And for how long the patient has it? Like for 6 months. And resolve with drinking sips of water. And it is recurrent, which means intermittent. It's not there always. So what type of pathology that can cause intermittent? If you remember the diagram, solid, intermittent, that means there is narrowing. Sometimes large bolus will stop and then pass. Either it could be esophageal ring. There's one differential diagnosis. Esophageal spasm, unlikely. Why esophageal spasm unlikely? What's the presentation of esophageal spasm?
No pain. There will be pain, most likely.
There will be
Chest
choking.
pain. Exactly, chest pain. No, usually dysphagia and chest pain, right? Unlikely because he's a bronchial asthma, recurrent, intermittent, solid food, and there is in the scenario there's one clue, it's very important, which is eating steak. Right. The right answer is eosinophilic esophagitis. He's young, male, with his allergy or bronchial asthma, and always in the exams مو اختباراتنا حنا اي مكان سواء في الهيئه برا USMLE usually they put eating steak. You have to remember this buzzword whenever they are put in the exam. Eating steak, think about eosinophilic esophagitis. And he has history of recurrent episodes of solid food dysphagia, so it's not liquid, solid, which is like unlikely motility disorder. And no weight loss. Another clue. Eosinophilic esophagitis unlikely to be associated with weight loss, but achalasia, yes. Esophageal ring, it is differential diagnosis, but this more common with bronchial asthma, then I will think of eosinophilic esophagitis, not esophageal ring. Achalasia different. We'll come to it. طيب, foreign body as a part of causes of dysphagia can be due to foreign body, usually chronic or acute. Usually acute. The patient just ate something and he felt the food stuck. So acute dysphagia occur as a result of foreign bodies and food impaction in the esophagus. Usually present with odynophagia, foreign body sensation, excessive secretion. ممكن واحد ياكل شوكة بعد سمك. شوكة تسبب dysphagia. Odynophagia. After ingestion meat, most commonly beef, chicken, and turkey, which completely obstructing the esophagus lumen, similar to this one. This often will obstruct at the level of upper or lower esophageal sphincter. Why? Because they are narrow. These areas are narrow. Management keep MPO, secure airway, and EGD. Esophagitis is, it's very important to know this definition. It's chronic inflammatory disorder of the esophagus. Clinically, how the patient will present with dysphagia, food impaction, so esophageal dysphagia, history of food impaction. And if you perform endoscopy, you might see this appearance with tracheization of the esophagus, longitudinal furrows. They might have micro abscesses, but you will see the most important histological finding is eosinophilic infiltrate, because it's associated with bronchial asthma, inflammatory process. Eosinophilic infiltrate more than 15. This is the clue. More than 15. If it's less than 15, it's not eosinophilic esophagitis. Can be due to GERD, can be due to Crohn's, can be due to parasitic infection. Many diseases can cause eosinophilic esophageal eosinophilia, but less than 15. If it's more than 15, then this is diagnostic for eosinophilic esophagitis, providing there is no other causes of eosinophilia. There is certain disease like eosinophilic gastroenteritis, they will have high eosinophilia in the esophagus, stomach, and small bowel. So you should rule out other causes of eosinophilia, but the magical number is 15. Always remember 15. I present with heartburn, chest pain, symptoms of GERD associated with food allergy, allergic rhinitis, atopic dermatitis, asthma, common in male more than female, adult more than children. Esophageal can show esophageal rings and narrowing. Diagnosed with biopsy. Treatment is BBI, steroid, swallowed steroid. 6 food elimination test. هذا common في الهيئة، اختبار الهيئة. All of the following is a part of 6 food elimination test except, or diet except. So what are the 6 type of food? Milk, wheat, soy, egg, nuts, and seafood. These are allergy, can cause allergy. Right. Endoscopic treatment, if there is a stricture or narrowing, we can do dilatation. Webs and rings, it's different from eosinophilic esophagitis. In terms of there is thin mucosal fold through into the esophagus, esophageal lumen, can be upper or lower. In the upper part, it's full thickness mucosal fold. We call it web. If it's occur at the lower esophagus, we call it esophageal ring. The upper esophagus associated with Plummer-Vinson disease due to iron deficiency anemia, and the lower esophagus or esophageal ring, which called it Chatsky ring, associated with hiatus hernia, eosinophilic esophagitis. So eosinophilic esophagitis can cause rings. They can partially or completely compress esophageal lumen, asymptomatic, or present with intermittent dysphagia for solid food. Diagnosis, upper endoscopy or barium study. Barium which will show this indentation or opacity in the esophagus, and endoscopy will show the rings.
دكتور
تفضل.
زاد فضلك. بالنسبة لل ايزنفليكس اسوفيجايتس، ايش العلاقة بينه وبين الستيك؟
ايه ستيك لين ولا ناشف؟
على حسب، بس غالبا لين.
ثيك حسب ويل دان ولا ميديوم رير. هو ديبند، اتس ثيك يعني بيف ميت. بعض الناس يقول مع الخبز، يقول اكل خبز مثلا ينشف حسب الغصه بعد الخبز. depend يعني it's not something يعني soft, it's not something liquid. لكن في التكست بوك common يعني يكتبون after stick.
تمام واضح دكتور شكرا.
50 years old complain of progressive dysphagia for solid food and solid and liquid. Solid and liquid. It's associated with chest pain, regurgitation, undigested food, and has history of weight loss. Barium swallow was performed. You can see the barium swallow. There is, who will describe this barium picture?
Bird beak sign at the lower esophagus.
Excellent. And what else?
Dilation of above the.
Excellent. Excellent. There is proximal dilatation of the esophagus and there is bird beak appearance or rat tail. طيب. So what's the best next step? Is it like esophageal manometry, gastroscopy, pH study, or CT chest? ثلاثة وعشرين ما جاوب منتظرينكم. طيب majority of you choose esophageal manometry. 14 choose gastroscopy. 1 choose pH study with impedance. 2 choose CT chest. Right. If you perform endoscopy for this patient, first of all, he presents what type of dysphagia? Oropharyngeal or esophageal? Oropharyngeal or esophageal? Esophageal. Right. Does it look like due to mechanical or motility problem from the scenario? Motility. Why? Because he had solid and liquid. So I'm thinking motility. Like in this picture, we describe it as like this dilatation proximal esophagus with narrow at the end. So if you did endoscopy, what do you expect the appearance of the esophagus from inside? If you look at the inside, what do you expect? How does it look? Narrow, distal, okay, there is narrow distally, and dilatation proximal, right? Right. What's the diagnosis? Okay, a structure at the lower, achalasia, excellent. Right. This patient is elderly and presented with picture of motility disorder due to esophageal dysphagia or esophageal dysphagia due to motility disorder. And he's having regurgitation. This is feature of achalasia, right? Regurgitation of undigested food because it's not passing here. There is severe narrowing, failure of relaxation of lower esophageal sphincter, right? And he has history of weight loss. So feature of achalasia again, weight loss. And dilatation, even another feature of achalasia, dilatation esophageal sphincter. So it's true. We have to do barium. We have to do manometry. But since the patient is 50 years old, we have to perform even before barium endoscopy. Why? We have to rule out malignancy. Similar to the previous picture. Wait. Okay. This patient, if let's say he's having more severe or larger mass compressing all this area and you did barium for him, he will give you the same picture of bird-beak appearance, dilatation of the esophagus, and narrowing of the lumen. So it will be the same picture, but you will not see this lesion in the barium. And other cause, malignancy can cause pseudoachalasia. So he's having progressive dysphagia, solid and liquid, associated with regurgitation and weight loss. So the patient might have pseudoachalasia. So the
طيب دكتور
تفضل.
بناء على العمر احنا سوينا اندوسكوبي ولا اي عمر راح اسوي اندوسكوبي؟
لا طبعا any patient with dysphagia should undergo endoscopy regardless. طيب which one is first, motility or barium, and motility or barium, it's case by case, right? But even before motility, before motility study, you have to perform gastroscopy, endoscopy. In this patient, I will think about malignancy, or before I label any patient with achalasia, I have to rule out malignancy. But what's achalasia? What's achalasia?
motility disorder
تعرفون عن achalasia?
of the neural plexus.
Excellent. So
there will be
the
a
neural plexus will
hypercontraction.
be affected. Yeah, there's three types of it, but the hallmark lower esophageal, the hallmark lower esophageal sphincter, it's not relaxing, right? There is increased pressure of the lower esophageal sphincter. The patient might have dilatation or atonic or increased contraction of the esophagus. So I can not any patient with failure of relaxation, you have to rule out malignancy. But again, let's go back to the definition. Neurodegenerative disease, incomplete lower esophageal sphincter relaxation, loss of esophageal peristalsis, present with dysphagia for liquid and solid, chest pain, regurgitation. Other causes like infection with the Treponema cruzi, which was, what do you call it, Chagas disease, هذا common في اليوسملي. It can lead to achalasia. Age can affect any age, but mostly between age 20 and 60. There is something called pseudoachalasia. If there is a tumor infiltrating ventricular plexus, it can cause achalasia picture. Or the patient have paraneoplastic syndrome, which is extra GI system malignancy, antibody affecting the ventricular plexus can cause pseudoachalasia, cause failure of relaxation of lower esophageal sphincter. So the patient does not have like a primary motility disorder, he's having malignancy mimicking achalasia. So any patient with dysphagia suspecting achalasia, you have to rule out malignancy. Clear؟ هذا قبل موتيليتي، قبل ما تسوي له أي موتيليتي. واضحة؟ Bottom line, achalasia, rule out pseudoachalasia. Also diagnosed with barium study, similar to this picture. EGD, usually if it's true achalasia, it can be normal, or there is dilatation of proximal esophagus with narrowing or decrease of the lumen of lower esophageal sphincter, or hypercontracted lower esophageal sphincter. Manometry, it will show, remember the first picture, there is relaxation of our esophageal sphincter with propagation of contraction of the esophagus and relaxation of lower esophagus. It will show maybe upper relaxation of our sphincter, no propagation of the contraction because hypercontractile, and there is no relaxation of lower esophageal sphincter. This is a picture of achalasia. Treatment, we can do something called POEM, which is myotomy, similar to Hiller myotomy, surgical. By endoscopy, we can make incisions in the middle of the esophagus and tunneling and cut the muscle. Pneumatic dilatation, we can do a botulinum toxin injection. Clear? طيب diffuse esophageal spasm, other motility disorder. The patient present with recurrent dysphagia and chest pain. Recurrent dysphagia and chest pain. More common after ingestion, very cold or very hot water or food. Finding in barium swallow study called corkscrew esophagus due to simultaneous contraction. It's not one part of the esophagus contract, all contract at the same time. Manometry will show premature contracture. Treatment, calcium channel blocker or tricyclic antidepressant. Let's take one question. هنا الآن 50-year-old 50-year-old male with history of heartburn for more than 20 years. Present with GI complaint of progressive dysphagia and solid food over the last 3 months. No weight loss documented. So what's the likely diagnosis? طيب. Is it atresia, esophageal spasm, peptic stricture, or hiatus hernia? So what we can see in this picture, let me show the answers. دائما 11 واحد ما يجاوب. ما ادري هو موجودين معنا فاتحين الجهاز وماشيين ولا. طيب. بس على فكرة ترى بوقت التحضير احضركم ويعني البعض اغلبكم يكون موجود لكن ما يكون في مشاركة. على فكرة اقدر ارجع انا واشوف اللي ما اختاروا، اعرف ان هم كانوا موجودين مشغلين الجهاز وماشيين، يعني ما هي بصعبة المسألة هذه. فأتمنى الجميع يشارك، يعني بالنهاية لكم المحاضرة، ودكم تحضرون احضروا ما تبون بكيفكم. لكن المحاضرة اللي فاتت حتى فيه بعض الزملاء خلصت المحاضرة وبعدها نص ساعة وهم موجودين بالقاعة ما شاء الله، ومنتهي المحاضرة من زمان، باين انهم مشغلين الجهاز وماشيين فعارفين انفسهم. فأتمنى الجميع يشارك، يعني 11 واحد وهم موجودين معنا. طيب. So what do you see in this picture? 50 years old, presented with heartburn over last 20 years. So he's having heartburn for 20 years. Presented with GI complaint of progressive dysphagia. One, progressive dysphagia for solid food over the last 3 months. No weight loss documented. So is it esophageal or oropharyngeal dysphagia? First step. Esophageal. Is it motility or structural pathology? Looks like. Structural. Is there risk factor for certain disease here? GERD. Okay. So what are the complications of GERD? Is it Charesia? Unlikely because it's not motility. طيب. Esophageal spasm? It could be, but it's progressive. He's having reflux for a long time and there is no pain and it's not intermittent. Hiatus hernia? Could be, I'm not sure, but we have to investigate. But it's not related to the risk factor. Peptic stricture? Likely peptic stricture. So what do we see in this picture? Do we see malignancy? It doesn't look like malignancy. What we can see here, there is sphagitis, linear erosion, there is narrowing of the lumen, and dilatation proximally. I cannot see any mass, likely due to prolonged reflux symptoms. Hiatus hernia, this is not the picture of hiatus hernia. He might have hiatus hernia, but I cannot see it. Maybe down there, but we have to go with the scope first. طيب.
دكتور سؤال
esophageal structure اتفضل.
دكتور بالنسبه لمثل الالسرز اللي قبل شوي، حكم البيشنت يعني عمره 50 وعنده هيستوري اوف جيرد، يعني هل لازم نسوي مثلا كونفرميشن انه مو كانسر اساس عند مثلا بايوبسي؟
طيب اعتقد تجي الحين المحاضره اللي هو بالنسبه لل when to screen patient, when to perform endoscopy for patient. If a patient have history of reflux disease and present with dysphagia, you have to do endoscopy. So must.
البايوبسي
Any patient with dysphagia, biopsy is very important here. Very important. And sometimes if we see this picture, I will give him high dose BBI. I will follow endoscopy later on. But in this scenario, maybe he need dilatation because it's even the scope diameter around 10 to 12 millimeter. Maybe it will not pass this lumen. It's very tight. So stricture can present with solid food dysphagia, gradually progressive, most commonly due to acid reflux. Other causes, acoustic injury or radiotherapy, pill-induced esophagitis like potassium chloride. It's rare, but can cause esophagitis, severe esophagitis. Eosinophilic esophagitis can cause stricture. Benign eosinophilic esophagitis, benign esophageal stricture due to reflux, can be malignant. Close proximity to GE junction, usually at the end of the esophagus, barium or AGD are the best diagnostic source. In this picture, you can see that there is guide wire inserted and then balloon, and the balloon was inflated to perform dilatation. You can see the esophagus now is dilated, and this is the guide wire inside. How it occur? Esophageal stricture or peptic stricture. Usually, patient might have hiatus hernia. You can see part of the stomach, it's pulled out in the chest, and you can see the diaphragmatic indentation on the part of the esophagus. So there is no valve, there is nothing prevent acid reflux. So with prolonged exposure to acid, it will cause inflammation of the esophageal mucosa and cause ulceration. With time, it will change into fibrosis, become fibrotic, and cause stricture. Barium study can show this appearance. This will lead us to GERD, which is the main risk factor for peptic stricture. So what's normal normal physiology for lower esophageal sphincter? Usually it has like rhythmic contraction. It will open and close. Once the food bolus came from esophagus, it will open to pass it to the stomach and then close. Sometimes there is transient reflux of gastric content to the esophagus, and the saliva will clean it out. If there is weak in the lower esophageal sphincter, weakness will cause reflux symptoms. The gastric content will go to the stomach. Normally, there is a contraction or rhythmic contraction of the lower esophageal sphincter. If there is weak or delay in the closure of this rhythmic contraction, can cause prolonged exposure of the esophagus to the gastric content, which will cause esophagitis. Other risk factor hiatus hernia, delayed esophageal clearance due to either decreased motility, like in scleroderma, for example, or also connective tissue disease like scleroderma, can cause xerostomia or decreased salivation, which will lead to decreased clearance of gastric content or gastric content that went to the esophagus. Other risk factor, obesity, hiatus hernia, smoking, non-steroidal, history of H. pylori. Here is written chronic atrophic gastritis or H. pylori infection, inverse association. What does it mean? Does H. pylori cause reflux or not? Is it protective or risk factor؟ وش علاقة ال H. pylori بالرفلكس؟ بمعنى لو واحد عنده رفلكس تبي تسوي له H. pylori test ولا لا؟
إلا بسوي له، لكن هنا ما فهمت المقصد صراحة إنه اللي أذكره دكتور إنه إلا it has an association.
طيب وش معنى inverse relation؟ وش المقصد فيها؟
If one is present, the other is decreased.
البارح واحد جاني في العيادة يقول كان عندي جرثومة عالجتها وزاد الارتجاع عندي، وش العلاقة؟ طيب let me tell you. If the H. pylori will cause gastritis and inflammation of the mucosa. Okay, هنا خلينا نشوف الإجابات. Risk factor H. pylori protect itself to decrease pH rebound. Okay, طيب. If H. pylori cause bad gastritis, so involving the whole stomach, so acid secretion will decrease. So it will decrease, it will be protective against reflux symptoms. If H. pylori cause only antral gastritis, what do we have in the antrum? We have the D cell. D cell, which suppress acid secretion. So the acid will be secreted without suppression. So gastric acid will be increased. So the patient will have reflux. If you treat patient with H. pylori who has bad gastritis, this will lead healing of the mucosa and increasing of the of gastric acid production. This will cause increased reflux. If a patient with antral gastritis only, if you treat it, the D cell will inhibit gastric acid secretion. It will help to reduce reflux. So that's why it's not indicated to check for H. pylori in patient with reflux disease, because you cannot tell, but it has associated with it, right? The risk factor could be aging, irritable bowel syndrome, anxiety, depression, family history of GERD. There is different etiology for reflux disease. Could be dietary factor like chocolate, coffee, smoking. All these can cause reflux. So what are the presentation? What are the symptoms of GERD, gastroesophageal reflux? Heartburn, excellent. What else? Vaginal like, okay, chest pain, let's say. Okay. There is two parts or two categories. Could be esophageal symptoms or extraesophageal symptoms. The typical symptoms for reflux are heartburn, regurgitation. If patient described as a heartburn والحرارة regurgitation, food that coming out of the stomach. This is symptoms of reflux. The patient might have atypical symptoms. What do you mean by atypical? We mean reflux can do it, but it's not the only reflux responsible for these symptoms. Dysphagia can be due to reflux or other etiology. Odinophagia can be reflux, can be other causes. Chest pain could be MI, not only reflux. Other extraesophageal symptoms like bronchial asthma. Asthma is not due to reflux only. Reflux can cause uncontrolled bronchial asthma. It might be, but it's not the only reason. Cough, laryngitis, dental erosion, pharyngitis, sinusitis, otitis media. These are atypical symptoms or atypical presentation of reflux. So don't blame reflux for any of these symptoms unless you rule out the primary etiology. No clear cause, then think of reflux as it could be one of the differential diagnoses, one of the etiology. So if a patient came with bronchial asthma, will you refer him to GI or pulmo? If patient came with sinusitis, you will refer him to GI or ENT. If all the primary cause or the like cause was excluded, then think for atypical causes. Like how to diagnose based on classic symptoms like regurgitation, heartburn, EGD. If you see endoscopic findings suggest reflux disease, pH monitoring. pH is not the same manometry. Manometry will measure the esophageal pressure due to contraction. pH study will measure the exposure of acid, exposure of esophagus to the acid. There are two types. Something we call ambulatory pH study with impedance. The patient will carry machine or device, and catheter will be inserted into the esophagus. Once there is acid reflux or gastric content reflux into the esophagus, it will measure the acidity, the pH, and it will record it. Once the patient felt the symptoms of reflux, he will push the button, and it will record the timing when he pushed the button, which means the timing he felt the symptoms, and it will record the pH at the same time. After 24 hours, the machine will be analyzed. If there is symptoms of reflux and the machine recorded there is exposure of acid gastric content, this information will be run through different calculation, different numbers, and it will tell us, is there association between the symptoms and the gastric reflux or not? If there is association, then this is reflux, GERD. If there is no association, that means his symptoms is not due to GERD. Could be other etiology. The other machine called Bravo, again, similar concept. There is a small device will be planted in the esophagus, and it will transfer this information wirelessly without the catheter. The difference here with impedance will measure acid or non-acid reflux. pH wireless only will record acid exposure. So how to treat GERD? First, lifestyle modification, elevate the head of the bed. Avoid eating within 3 hours before going to the bed. Why is that? Why eat meals that moderate size and fat content? What's the relationship between the time, the size, and fat content? Yeah, food will be still in the stomach. If patient eat large size meal, it will take longer time, more than 3 hours to be digested. Fat content, usually it will take longer time for digestion. That's why the patient advised to eat small, moderate size meal 3 times a day, and they can take snacks in between and go to the bed after 3 hours from last meal and elevate the head, because if once he lying flat, this will be open and all gastric content will go up. Weight loss. What's the relationship between weight and GERD? What's the relationship؟ في علاقة ولا ما في علاقة؟ اوكي risk factor why؟ اوكي
لا في علاقة.
why؟ سام؟
الفات بتسوي ديستركشن يعني فيرفع نسبة جير.
Sphincter, okay. Obesity associated with risk factor for hiatus hernia. If they have hernia, hiatus hernia, so they will be exposed or they will have reflux symptoms. Another thing, obesity will cause increased intra-abdominal pressure. Excellent. Similar to the pregnancy, early pregnancy or middle of the pregnancy, usually the pregnant lady will have reflux symptom. Why is that? Increased intra-abdominal pressure will compress the stomach, so this will cause reflux of gastric content into the nearest exit, which is, if not duodenum, it will be the esophagus, and will cause relaxation of the sphincter. Right. Weight loss, reduce intake of caffeine and chocolate because it can cause relaxation of esophageal sphincter. Stop smoking, anti-acid or acid neutralization like Gaviscon, the most common Gaviscon. Acid suppression with medication, histamine and H2 blocker, proton pump inhibitor, prokinetic. Please never give patient with reflux prokinetic like metoclopramide. It's not useful. Even the newest guideline just maybe it is like 3 months ago, maybe 3 or 4 months ago. They are against use metoclopramide, so never give metoclopramide for any patient with reflux disease unless they have gastroparesis. Gastroparesis, not for reflux. Okay, laparoscopic surgical treatment can be independent application, can be complete or partial. There is something endoscopic we can do, like something we call it TIF, different procedure that can be done. Aye. Question. So 55-year-old patient complaining of reflux symptoms and nausea. He was treated with omeprazole 20 milligram. His symptoms is not improving. Physical examination was a remark. So next step, add ranitidine at bedtime, perform endoscopy, increase omeprazole to 40, follow up after 2 weeks. Let's see the answers. If you choose increased omeprazole dose, ranitidine 5, okay. So this is the correct answer. Whenever you have reflux symptoms not controlled with omeprazole, always optimize the medical therapy. Patient refractory GERD, when we call refractory, patient have persisting symptoms despite twice daily VI therapy. Be given twice, you can increase the dose. If it's 20, make it 40. If it's already 40, you can make it 40 BID. and make sure the patient is compliant in the medication. Sure he's taking BBI 30 to 60 minutes before meal. If all is failed, perform endoscopy to communication. Like what communication? Could be to esophageal stricture, could be Barrett's, be phagitis, or any other. If endoscopy is normal, then BH study might be needed. So to do endoscopy patient with hiatus, yeah, sometimes we can give higher dose up to 40 milligram BID for 2 weeks or even 1 month. It is not usual dose if the patient has severe esophagitis not improving with standard dose medical therapy, we can upgrade. But it's not the standard dose. لا تجي order ما يجي تعطوا 40 BID for 1 month 2 months. No. Start 40 milligram. If he's improved, decrease it to 20 or make it every other day or PRN once if it's needed. If he not improve the compliance, if he is compliant, maybe you can increase the dose and follow. If not, do endoscopy to rule out complication. And make sure he's taking medication 30 minutes before the meal. So when to perform endoscopy? If patient have reflux symptoms, not responded to therapy even after optimization. Odinophagia, weight loss, GIB. These are alarming symptoms. I don't wait for medical therapy. I perform endoscopy. If a patient had imaging and there is abnormal finding, persisting vomiting, recurrent symptoms following surgical therapy. Let's say patient have sleeve gastrectomy, for example, or he's having niacin fundoplication and he's having symptoms, then perform endoscopy to check to see the anatomy. If you are suspecting the patient have Barrett's esophagus, then screen the patient. Once we perform endoscopy, the common finding, it's normal esophagus, no erosion, nothing. This we call it NERD or non-erosive reflux disease, which is presence of typical symptoms of reflux with no evidence of esophageal mucosal injury at the endoscopy. So he's having the reflux symptoms, but endoscopy normal. This is common finding. That's why we don't need to do endoscopy initially. Just give him the medication, optimize it. If not respond, then EGD. Or we might find erosive esophagitis, linear erosion starting from gastroesophageal junction, which might progress involve larger area leading to circumferential involvement and stricture formation. We have something called LA classification. LA grade A, it's one or more mucosal break at lower esophageal, less than 5 millimeter, not bridging. This one, very small. This is mild reflux. Or he might have larger than 5 millimeter mucosal break. Grade C, moderate to severe circumferential involvement, less than 75% of the surface, or severe more than 75. You can see the erosion more, the whole circumferential. Comparing here, area, normal area and eroded area. So if EGD normal or NERD and he's having typical symptoms, what we do, BH study with impedance, test for reflux and non-acid reflux. If BH testing was positive, there is typical symptoms with exposure, documented evidence of acid exposure at the time of reflux symptoms. This confirm the reflux. Then we make sure of the compliance, increase the dose to BID, we might add H2 blocker. If the test is negative for acid reflux, so there is no association or there is no reflux, then we might call it functional heartburn, which is normal pH study. There is no reflux, there is no recorded acid exposure with typical symptoms. If there is no atypical symptoms with normal pH study, then stop BBI because it's not GERD. GERD is a spectrum from erosive esophagitis that the patient has a true acid exposure, and during endoscopy we can see erosion and ulceration, or the patient have true exposure of acid into the esophagus with normal endoscopy, or patient have a true exposure but not significant. The total pH exposure less than 4.2% of the total time. It's based on certain calculation you don't need to know about. So he's having exposure of acid, but it's not that much, but he's having typical symptoms. We call it reflux hypersensitivity. The treatment is different from regular reflux symptoms. Or the patient have no acid reflux. There is no documented reflux, and he's having atypical symptoms. We sometimes call it, or the patient have typical symptom, but there is no acid reflux. Typical symptoms here, but there is no acid. We call it functional heartburn. كلير. طيب هذه آخر slides ما بقي شيء. طيب let's take this question. يقول a 60-year-old male patient known to have chronic reflux for several years gets roscopy shown salmon color mucosa at distal esophagus. Biopsy showed columnar mucosa with intestinal metaplasia and goblet cell. What's the most likely diagnosis? Barrett esophagus, reflux esophagitis, eosinophilic esophagitis, Palmer-Vincent syndrome. هذا السؤال أعتقد من أسئلة الهيئة السعودية حقت الاختبار اللي هو الاس ال اي. عارفين الاس ال اي أكيد. هذا من اختبارات الهيئة. يعني جايكم بيجيكم من المحاضرة هذه في الهيئة. لا مو بسيستمك روبوت الله يهديك. السعودي لايسنس اكزام. هذه بعد ما تخلص إن شاء الله علشان تدخل التريننج ريزيدنسي لازم يكون عندك نجحت في الاختبار حق الهيئة. Let's see the answer. Majority of you choose Barrett esophagus. Excellent. So feature of Barrett or the clue in the history or to diagnose Barrett. خلنا نغير هذه دقيقة. Feature of Barrett, endoscopic feature and histological biopsy. Endoscopic feature, you will see the mucosa at salmon color looking mucosa at the distal esophagus. And biopsy will confirm, it will show columnar mucosa with intestinal metaplasia and the most important goblet cell. Reflux, it shows just inflammation. It might shows eosinophilic esophagitis will show more than 15 eosinophilic infiltrate. Palmer-Vincent is different, will show rings. This is a picture of salmon color esophageal mucosa. This complication of GERD can be esophagitis. I show you a picture. Barrett esophagus can cause anemia, esophageal structure. So once you see this salmon color mucosa, then think of think of Barrett esophagus, then biopsy should be taken. So it's pre-malignant condition, pre-malignant, that's why it's important to know it, in which normal squamous lining of lower esophageal replaced by columnar mucosa, seen endoscopically as salmon-colored mucosa, and with histology will demonstrate intestinal metaplasia with goblet cell. So this is the normal esophagus, normal squamous cell. Once it's exposed to acid for a long time, it will cause esophagitis and erosion and mucosal break. With time, it will change the color to salmon appearance, and then it might show dysplastic feature starting to be malignant, and then it will develop cancer. So from normal to esophagitis to Barrett to metaplasia and cancer. هذا من الهيئة حتى. 60-year-old patient, heavy smoker with long-standing GERD. Upper endoscopy showed squamous cell with high-grade dysplasia. High-grade dysplasia. What's the best next step? Counsel him regarding smoking cessation. Refer for possible esophagectomy. PPI and follow up after 6 months. Follow up after 3 months. Remember, high-grade dysplasia. Let's see the answer. Majority of you choose B, which is refer him for esophagectomy, and 14 choose for up 3 months, 5 choose 6 months, and 5 choose counsel. طيب مين اللي شاف الأسئلة الهيئة؟ مين اللي قرأ الأسئلة؟ لأن ال 21 واحد هذول قارين أسئلة الهيئة. في حد عنده المذكرة وشافها؟ لأن يبدو لي أنها موزعة ومكتوبة ومحلولة. The answer was written as B, refer for esophagectomy, which is wrong answer. حتى اللي حل غلط. This is wrong answer. Why is that? عشان لو رجعتوا لها وشفتوها بعدين تعرفون why it's wrong answer. The true answer, follow up after 3 months. طيب. So we mentioned that Barrett is risk for cancer. Barrett can cause dysplasia. So whenever we see Barrett, we have to take biopsy. And based on the biopsy, we'll decide what we shall do for this patient. If the biopsy showed no dysplasia, right, then we'll do EGD with sampling with no dysplasia. We repeat EGD after 3 to 5 years. Ablation is not recommended. What do we mean by ablation? Right. Most of the procedure we can do it as a GI. We don't need surgeries. Right. In the past, for any malignancy or early malignancy, high-grade dysplasia, they can do esophagectomy, but not anymore. There's different endoscopic treatment can be applied, can be due to with ablation, with AMR, endoscopic mucosal resection if there is nodule. With endoscopy, we can do a lot of things, so we don't need major surgeries. So if the biopsy, there is Barrett, and by histology endoscopically showed salmon color mucosa, we took biopsy, showed intestinal metaplasia with goblet cell, and showed no dysplasia, then repeat endoscopy after 3 to 5 years, because it has low risk of malignancy. So if undefined for metaplasia, we are not sure is there metaplasia or not, then repeat EGD within 3 to 6 months. Now the most important, if there is low-grade dysplasia, then we have to repeat endoscopy within 6 months to make sure, is it really low-grade dysplasia or not? Why? Because the management, the patient at higher risk of cancer. And the problem, some histopathologists, they will not agree on the same reading. They will not agree on the same interpretation for the slide. So it has to be confirmed again, confirm the presence of degree of dysplasia with two expert pathologists. Two expert pathologists in esophageal dysplasia, not any pathologist. Because if you send that biopsy for one histopathologist and the other biopsy for another one, they might give you different. One will tell you it's low grade, and the other one will tell you it's high grade. So that's why you have to repeat to make sure, is it really low grade dysplasia? And two expert histopathologists. If yes, low grade dysplasia, then surveillance, we have to repeat endoscopy after 1 year until no dysplasia and two exam. Or we can apply endoscopic ablation, or if there is nodules similar to this one, how do you call nodule? If there is nodules similar to this one, a nodule we can remove it by endoscopy, something we call endoscopic AMR, endoscopic mucosa resection, right? If there is high grade dysplasia, مثل السؤال اللي جاء في الهيئة, if there is high grade dysplasia, then confirm with another EGD biopsy within 3 months. Again, within 3 months with two expert histopathologists. If nodular, then we'll do AMR, endoscopic mucosa resection, or endoscopic ablation. No surgery. Surgery is not easy decision. انت لو ارسلت المريض عشان يشيلوا المريء حكمت عليه بالاعدام. Especially إذا كان histopathologist is not sure. So confirm the finding first with two expert histopathologists. Repeat it again after 3 months. If it's low grade, follow up after 1 year. If it's high grade, then endoscopic ablation by different methods you don't need to know about. Clear? أعتقد هذه آخر سلايد. أي سؤال؟
نقطة واحدة دكتور، اللي تو نتكلم عنها واللي بالسؤال أحسها غير بعض، ولا نتكلم عن بارت اسوفيجايتس، واللي قبل
كيف؟
نتكلم عن سكويمس سيل ديسبليزيا، وكلها نعتبر
سكومس سيل with high. لا regardless. طب شوف، أنا نقلت السؤال كما هو بغض النظر عن الوردنج، بغض النظر عن السيناريو، لأنه مفترض ما ندخل حتى بالاشياء هذه، بس عشان اعرف وش اللي قاعد يصير بالريال وورد. الزال السؤال في الهيئه something، اللي نقرا السؤال غير فيه، اللي سمعه واللي كتبه يمكن غير فيه. تعرف زي قصه تلفون خربان، كل واحد ينقل معلومه ويغير فيها. السيناريو اصلا كان كله غلط، زين، والاجابه كان كلها غلط. بس بما ان جاء الكونسبت، الايديا هذه انه هاي جريد ديسبليزيا وات شيل يو دو وذ ذيس بيشنت، انا جبت السيناريو هذا نقلته كما هو. زين. فانتم بتقرون اسئله من حقه الهيئه اكيد فيها اخطاء كثيره، فلا تحفظ مكانه وتحفظ شكله وتروح تحلها على بدون ما تتاكد.
اي واضح. انا
زين. لكن ان جنرال اي لا بغض النظر عن السؤال، بس انه اذا قريتوا السؤال هذا ترى غلط المكتوب في المجمعين زملائكم. اللهم صل على محمد. هو الايديا patient with reflux has Barrett. البارت يكون intestinal metaplasia with goblet cell. هذه الماركس حقتها goblet cell. It can show dysplasia or no dysplasia. Dysplasia can be high or low grade dysplasia. Low grade dysplasia and high grade dysplasia are risk for cancer. Risk for cancer we have close follow up. إذا كان في nodules therapy. واضحة؟ إذا كان فيها كانسر again depend on the extension of the cancer، في lymph node، TNM classification وشغلة ثانية ما تهمكم هذه كلها.
دكتور
ممكن تفيد جزئية النديولز، وش نسوي إذا كان في نديولز؟
طبعا اوكي طبعا في تشوفون اي نديولز هنا ولا كلير؟
لا كلير.
كلير صح؟ sometimes you find lesion يعني small bump. طيب small bump يعني زي كذا طالع نتوءات خلينا نسميها، هذه تسمى نودولار. حلو. اذا كان احنا مثلا نرجع لهذه او مثلا هذه اخذنا بايوبسي، هذه فلات ليجن نسميها، طلع فيها ميتابليزيا. التريتمنت في الاندوسكوبي يختلف، في شيء يسمى كرايو ابليشن، في احيانا في الاي بي سي اللي هو ارجون بلازما ابليشن، ديفرنت تكنيك تو ابليت ذس اريا. ابليت يعني نحرق المنطقه نقول. اوكي، اذا كان في نديول لا لازم اشيل النديول هذه. كيف نشيلها؟ زي شيء يسمى الاي ام ار، اندوسكوبيك ميوكوزا ريسكشن. تذكرون حقه الفاريسيلا بليدنج، نحط الباند زي نسوي لها سكشن، نركب باند، بعدين كات ذس اريا. وفي شيء يسمى اي اس دي. ما تهمكم التفاصيل، انت يهمكم بس اهم شيء، بما انه ذكروا في الهيئه انه فيه high grade dysplasia need follow up, close follow up with another biopsy.
دكتور بس سؤال بسيط، بالنسبة للنو ديسبليزيا بعالجه ولا بس بسوي له اندوسكوبي بعد 3 سنوات؟
بي بي
وأعطي
اي
BBI
غالبا.
والاشياء هذه.
You give him BBI and close follow up. Follow up يعني repeat endoscopy after 3 years 5 years. طبعا كل هذا معناه في بارت موجودة. طيب السؤال، خلينا نحضر. طيب اللي يسمع اسمه رجاء يعني على طول يحاول يكتب yes tend anything. طيب نبدأ بجروب A أو جروب 1. ريان، خلدون عبد السلام، عبد الله.